MBBS student at Shalimar Medical and Dental College, and
I'm Salika Malik, and I'm a second year MBBS student at Fatma Jinnah Medical University.
we are going to be mediating the last session for today. Before we proceed, I'd like to ask the audience to kindly switch off your mobile phones to avoid any disturbances. Please also note that you may write any questions you have on the question cards that are handed out, and we will open the floor for questions at the end of the session.
The last session of today will discuss Sjogren's, scleroderma, and sarcoidosis, and I'm honored to announce that this session is dedicated to Dr. Shahid Abbas, who served as president of the Pakistan Society for Rheumatology from 2002 to 2004.
Before we begin, let us introduce our honorable chairs for session 3. We have Dr. Taqdees Khalik, who is an associate physician for rheumatology at the Federal Government Polyclinic Hospital in Islamabad. Please, Dr. Taqdees Khalik, come onto the stage. And Professor Muhammad Imran, who is a professor of medicine at Fatma Jinnah Medical University, Lahore.
I'd like to begin the session by introducing Dr. Maurizio Chiotolo, who is a professor of rheumatology and internal medicine, Director Research Laboratories at the Academic Division of Clinical Rheumatology and Director Postgraduate School on Rheumatology at University of Genoa in Italy. Dr. Chiotolo will be joining us online and will be speaking on Raynaud's to systemic sclerosis, the pathophysiological mechanisms.
Hello, good morning. I hope you can hear you. I can hear. Can you hear me?
Yes, we can hear you. Yes, we can hear you.
Oh, sorry.
How are you?
Okay. You can see me?
Yes.
Everything is okay?
Yes.
Thank
We
you.
can hear you and we can see you.
So, thank you very much for inviting me. And I'm sorry for this time I couldn't come personally, but I'm very honored to participate to the Silver Jubilee. And we had already yesterday a wonderful workshop on capillaroscopy, and we had occasion to discuss with many of you some important issues. Today, the lecture I was invited, it's regarding the transition from the renal phenomenon to systemic sclerosis, and looking at mechanisms for this transition from primary to secondary, the pathophysiology. If I can start to share my slide.
Yes, you can share your slide.
Thank you. Okay,
Yes,
I
yes,
hope
we
you
can
are
see.
able to see.
Yes, we can see your slide.
Thank you very much. So, this is my disclosures. Okay, the renal phenomenon is clearly well known, but the renal phenomenon is something more that is a simple symptom. And we know very well how is the beginning for the early symptoms of severe connective tissue diseases. And so here it's a little story, and mainly the passage from the primary that we well known, the sequence, to the secondary. The renal phenomena, as we know, it's characterized the primary for several triggers that may enhance this attitude. And this attitude is enhanced by situations that are part of the normal life. The constriction of the arteriole and the consequence reduced blood flow in the periphery. This is quite common in women, especially in young women. Almost 20-30% of women, young women, are affected by. And also, it's important that it's much frequent primary in the range age of 15-30 years. And also that must be idiopathic. In other words, should not at least associated with other connective tissue disease. In this case, we will see it's another kind of reason for the reduced blood peripheral flow. In fact, the secondary renal phenomenon is much more common in older age compared to the younger age, and is a patient referring to secondary or tertiary care center have associated connective tissue disease. But sometimes it's a very early symptom that starts many years before, when no markers, no other clinical symptoms are evident. And we can say that the secondary associated with connective tissue disease like systemic sclerosis, but many other diseases like SLA and others, it's a crucial symptom that tell us something very important. Tell us that endothelium, the vessels, are a barrier, a real area of exchange, but also are a very delicate potential, the endothelial cell antigen. And the damage of the endothelial cells, it's a beginning for a microvasculopathy that at the beginning is not evident. We can have just the lesion during the ischemia induced by Raynaud, but we don't have already clear signals of the sufferance of the organic suffering of microvessels. So the microvascular damage is a quite common beginning for several diseases. We include here also, for example, the COVID and SARS-CoV-2 affect the endothelial cells. And we discussed yesterday that very common feature of the microvascular damage you can observe in acute and post-acute COVID. But let me proceed. The endothelial cell hypoxia and reperfusion is a continuous stress for the endothelium, but also other reasons for damage endothelial cells and causes for secondary or at least associated with primary are, for example, chemicals. In this interesting study, workers in contact daily for 30 years with vinyl chloride monomer showed after 15 years from the retirement interesting changes in their microvascular capillary rate that was not associated with presence of antibodies without any correlation with the intensity of symptoms of Raynaud that were increases, in significant increases. But just to tell you that the reason for damage is not just the cold or the stress, but also chemical, is quite frequent. And ants are in contact with chemical. But the most important aspect is the role of estrogens. This is, like the majority of autoimmune disease, a clear disease of female. Female are affected by the majority of autoimmune diseases. And you know the ratio is in favor of females, especially when the autoimmune disease is characterized by the activation of B cells, production of autoantibodies, and so progression of the disease. So we can say that the estrogen serum concentration affect the polarization of the immune cells when start an injury, and much easier to start an autoimmune reaction against potential self-antigens or external antigen female, as well as the polarization of the cells, including, for example, monocyte M2, we will spend some words. It's driven by the effects, the main effects on B cells, and the enhancing role of circulating estrogen, especially 70 beta estradiols on an hydroxylated metabolite. This is, for example, just an interesting study that showed that in transgender treated with estrogen to complete the transition were affected by systemic sclerosis in this casuistic limited, but when was done a review, other cases were observed, suggesting that the hormonal modification as a part of the gender transition may be relevant in addressing the development of autoimmunity, in this case, systemic sclerosis. And this is well known that estrogen acts at different levels during the immune response, but also may condition the immune response. And estrogen in particular increase the maturation of B cells and their production of autoantibodies. So this is well known, even at level of macrophages, for the priming of macrophages together with the production, increased production at 12. So the estrogens, these are recent discovery, increase the activation of T2 helpers that are characterized by cytokines that in some way in systemic sclerosis are involved in the fibrosis, as well as a possible functional hepatogenetic role of the anti-topoisomerase antibodies that can bind to fibroblasts and may explain why the association with ATAD positive patients have a much more severe progression of the fibrosis. But other functional antibodies, for example, are the antibodies binding the platelet-derived growth factor receptors, acting like PDGFR, an enhancer of fibrosis. And even more interesting, as a functional antibodies, not just marker, but actor in the earliest steps of the immune response, the anti-angiotensin converting enzyme receptor against antibodies or endothelin type A receptors. Those antibodies act as real agonists with the receptors and stimulate and increase the vasoconstriction, and so are related with severe manifestations, like at the level of the skin, the presence of digital ulcer, but also pulmonary arterial hypertensions. And more, also not frequent researcher, but the anti-endothelial cell antibody that are detected even in this range up to 80% of patients bind to the endothelial cell topoisomerase 1, suggesting again that these antibodies may play a role in the pathogenesis. So not just bystanders, but actively involved in the relationship with damaged endothelial cells. You can see here the presence of anti-endothelial angiotensin enzymes are present in patients with connective tissue disease and pulmonary hypertension, or much more frequent in systemic sclerosis patient with pulmonary hypertension than against with idiopathic pulmonary hypertension, as well as angiotensin converting enzyme. And even the prognosis and the mortality in presence of such kind of functional antibodies that enhance from the beginning the development of the fibrosis may predict the pulmonary hypertension development in systemic sclerosis patient. So an important role of the interaction of the immune system and specific antibody with the endothelial cells. But even, and this is very important study, the presence of antibodies against the estrogen receptor alpha showed the presence in 42% of patients with systemic sclerosis. And this kind of antibody act as an answer again of and increase for example, the cells apoptotic susceptibility. So the presence of anti-estrogen receptor type alpha are absolutely other important players and maybe considered as promising markers for the progression of systemic sclerosis. And as I mentioned before, estrogen themselves used to play an important role in activation of the cascade, but here even antibodies may be agonists of estrogens with their receptors. So it's interesting that the cold, of course, induce, but the cold why induce much easier in female, the primary renal phenomenon in young female. Why young female are much more easier to start the primary. Here, this interesting study, they showed that the treatment of endothelial cells with concentration 70 beta estradiol increased the expression of the alpha adrenal receptors, and so much increased the number of receptors for adrenaline. So for the vasoconstriction due to the stress, due to the response to, for example, cold. So the presence of estrogen in some way predispose, and you see here the diameter of the vessel during this experiment is reduced, predispose the female gender to that higher response to the adrenaline, because there is a higher expression of the alpha adrenal receptors. And this is an interesting aspect that may explain also many other vascular aspects that characterize female compared to male. But important also the epigenetic. Here we know is a new field, but the importance of microRNA play a role. For example, microRNA 29 is a downregulator of TGF-beta, and was just finished 2 years ago a study administering the microarray 29 to reduce the activity of GGF-beta. So, and if we consider that estrogens enhance the epigenetic signals like methylation DNA, expression microRNA, we once again understand that the estrogens are hormonal, endogenous modulator of epigenetic reactivity, and so much easier again to display and switch off and switch on genes related to the disease than in male. So this is a quite complex story behind the transition from primary to secondary, but I think it's important to consider these important players. But we know that from the 70s that the analysis of the microvessel in a very safe way, like with the capillaroscopy, the early study from Merrick in the United States, and then now finally in the ACR EULAR guideline is introduced the capillaroscopy for the scoring and the detection of the damage. We know that the process of progression of the fibrosis, the progress of progression immune response, it's possible to be monitored by the changes we observed in microvessels from the beginning, because from the beginning we observe a progressive damage that starts with dilation, then prosecute with hemorrhages, with the deletion, loss of capillaries, angiogenesis, fibrosis, and so on. So it's clear that when we start the Renault, it's already behind the Renault when the phase and is about 60 to 20% of primary Renault will move during the years in secondary associated with connective tissue disease. The microvascular damage in connective tissue disease is under very sophisticated and early changes. You can see here a normal array. You see the normal regular position of vessels, microvessel, capillaries. Here, of course, may be associated the primary Renault phenomenon, because we know that primary Renault phenomenon is not necessarily associated with evident changes. But when start the process we mentioned, and so start the progression, here we have the development of changes. Here, imagine that there are all around antibodies, mediators, and other cytokines that may damage. You see the dilation. You see the red blood cells start to leave the damaged wall of the capillaries. And here, we don't have a real pattern, but this is now today, published the last month, a real very early pattern of capillary damage when the dilation is over 30 micrometers. So the progress of the endothelium may be monitored in a very safe way that is just the morphology. And then you have the classical giant that from the beginning are considered a clear marker of the early systemic sclerosis. So if you have a very early changes that is related to the beginning, to the growth of the giants, the progressive growth of the giant due to the progressive enlargement, at the beginning, all the cells involved in the damage of the capillaries that includes cell adhesion, migration, and even apoptosis on endothelial cells, the enlargement is limited under 30 micrometers. But when the disease move and the microvascular damage is the beginning for the local fibrosis, as we know. Here you see it is a skin histological evidence with infiltration of inflammatory cells, where I mentioned it. There are lymphocyte, monocyte, and here production of cytokines, antibodies, here inside the endothelial cell, here not yet evident strong fibrosis, but start. You see the vessels still open, but in this phase, you have a sort of microvascular immune inflammation during the very early. And in the early, this damage, of course, progress. The dilation become much more evident over the 50 micromolar, and you have the classical giant with loss of capillaries, of fluids, edema, puffy finger, or what you want, microhemorrhages, and you have the classical aspect of the active or early. Early, before, you see classical giant. This is already a marker of secondary renal phenomenon with the release of red blood cells, the microhemorrhages start, and you see the continuous progression of the damage in the early. And the early, of course, is followed by the active and then by the late. We must say that this continuous progression is pushed by estrogen, because estrogens, as I mentioned, are potent enhancer not only of B cells activation, but even of cell proliferation, for example. And so here we once again, I would like to stress how this kind of functional antibody, especially against endothelin, vasoconstrictor peptide, and angiotensin converting enzyme, vasoconstricted mediators, are increased in systemic sclerosis and are part of the early steps of the immune vascular reactivity, microvascular and immune vascular reactivity. Of course, then there are many other antibodies, as I mentioned before. At the end, the active phase is characterized by this dramatic loss of capillaries, then start with a high rate. If we have not been able to block the immune response, to block and to increase the vasodilation in order to let the tissue survive. And of course, edema and microhemorrhages characterize the pattern, as you can see here. Loss of capillaries. You see this yellow is fibrosis. You see hemorrhages. This giant is collapsing. In origin was like this, is collapsing and will die and leave another area, another vascular area. And this is the progression of the giant, their collapse. And you can see here different aspects, different situation, but all characterized by strong enlargement for damage of the endothelial wall and hemorrhage and then disappearance of the capillaries. And it's clear that the clinical consequences are evident, and here we are in the disease, in the full disease. And the full disease, for example, is characterized by skin lesions that are the classical skin ulcer, maybe small, maybe larger, maybe gangrena, but this is a signal that I lost capillaries, the fibrosis creates strong hypoxia, and the only possibility of defense is the increase of angiogenesis. So the production of new vessels that in any case are not able to reestablish the original microarray because are confusing way to try to reconstitute the microarray. And this is, of course, the late phases, the fibrosis. Fibrosis is a drama in the lung, interstitial lung disease, the pulmonary arterial hypertension, and then we know very well what happened in the kidney, and we know what happened in the gastroenterical system, and all kinds of cells, fibroblasts, circulating fibrocytes, resident fibroblasts, macrophage move from M1 to M2 that particularly fibrosis, but also adipocyte cells through the mechanism of adipocyte to mesenchymal transition become myofibroblasts. Same fate for the endothelium. This process was discovered 15 years ago. So, and the tissue, the angiogenesis try to reconstitute, but as you can see, in the late pattern, you have some angiogenesis. You do not have any more the normal array. You don't have any more giant or hemorrhages. It's a desert. And this is the worst situation. You can see on the face of patient this condition with fibrosis, loss of myxicity, and you see the angiogenesis like telangiectasias on spiders, and you see also the ischemia. This is an irreversible ischemia, but the angiogenesis also, unfortunately, is a tentative without a lot of success. And the same happened in the lung and in the other internal organs. So I think I am out of the time. So just to underline how the renal is driven from the functional Raynaud to the organic, irreversible secondary Raynaud by the damage of the microcirculation. And this is what we consider very important. And this is a very cheap, safe way to detect even the very early changes associated with the Raynaud. And if we can detect as soon as possible the presence of giants, so the secondarity of the Raynaud, we can also search antibodies, we can also understand the disease is starting, and with the new potent drugs or combination with immunosuppression, vasodilation, and possible antifibrotic therapy, we can reduce the progression and the severity of the disease. Thank you very much.
Thank you, Dr. Kitolo, for an excellent talk. Please stay with us for the Q&A session. Our next speaker for today is Dr. Shakib Sajid Qureshi, who is an associate professor at Rocky Vista College of Osteopathic Medicine in the United States and a consultant of rheumatology at Genesis Healthcare Consultants, Lahore. Dr. Shakib will be speaking on the disease with multiple faces.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. So, first of all, thank you very much for giving me this opportunity to be in the group of such esteemed people, Dr. Nighat Mir and all the stalwarts here. It's a pleasure and an honor. So, this is a topic actually I wanted to discuss more for myself rather than the teaching, because a topic that I thought that actually after even spending couple of decades in rheumatology, I think I didn't have a good grip on. So this is a short background of mine. I've served in USA almost like 20 years now in the field of rheumatology, and currently actually since 2019, I've transitioned from a very large hospital system where I was the chief of rheumatology to be working almost like as an international rheumatologist. I spend most of my time in Pakistan now, like 50 to 60%. And 40% still in US, and actually I'm going to Malaysia next week where I see like patients have like 1 week a year or twice a year. Gave some lectures there too. So I'm enjoying this phase of life, alhamdulillah, quite a bit. So this is a patient who presented to me actually in US just a couple of months ago, actually December of 2021. I'll quickly skip through the main history because it's pretty simple. The main issue was the chief complaint. She was like bilateral hand pain and swelling and stiffness. The other issues were chronic low back pain and knee pain. You can skip through the past medical, surgical, medication, etc. And on examination, which is the most important portion, I tell all the students, if there are students in the room, that the most important component of any patient care is the history and physical examination. Any good rheumatologist, by the time he's finished with a good history and a good physical examination, and every component of history taking is very important, including the social history, especially in Pakistan, where you've already made up your mind how to treat the patient based on their social status. Then the examination, she had synovitis of the bilateral wrist joint with reduced range of motion. So reduced range of motion also tells you that probably it could be a chronic disease. She had active synovitis in her right, second, and third MCP joints greater than the left hand. Synovitis in the right hand, PIP joints greater than the left hand. The rest of it was more like a 70 years old lady would have bilateral trochanteric pain, anserine bursal pain. She had Haberdines and Bouchard nodes and bilateral knee joint crepitus with edema of the legs. So again, for the students in the room, this is more of a slide for them that anybody who comes with a possible diagnosis of inflammatory arthritis, this is the basic workup all of us do wherever this is available. So CBC, RFT, LFTs, and urinalysis are important for not only diagnostic but therapeutic purposes. Uric acid, she's 70 years old, so I think we should check it. TSH, normal. ENA was negative. She had dry eyes and dry mouth in the review systems, so you want to rule it out. CCP and rheumatoid factor negative. Hepatitis viral panel negative. HLA-B27 was negative. CT angiogram chest done a few months ago was negative. This is the X-ray, actually not classic changes, but subtle changes of lacy reticular pattern in the DIP, in the distal phalanges. Slight cystic, mild erosive changes. Same goes in this hand. And this is the pelvic X-ray, slight degenerative changes. And this is actually not her x-rays, but this is probably the clue. You probably by now know what she has, right? Anybody in the room? Take a shot. Yep, very good. So one thing for the students, if you know something, speak up. Half of the things is speaking up and be confident about what you say. Feet, you can see. So in sarcoidosis, in arthritis, actually sarcoidosis, advanced changes, actually very first patient that I ever saw in my fellowship had arthritis mutilans. And everybody actually initially thought it was more of a psoriatic arthritis. Turns out that was sarcoid arthritis. So that actually picture is still kind of stuck in my mind, even after like 18 years. That is one of the manifestations. Then I saw like some mild sarcoid arthritis along the way, but then nothing like the one that I saw initially. As you can see that this is more, it can even be confused with easily with a psoriatic arthritis or a reactive arthritis with distal dissolution, but where you see the cysts are actually the key. This is an MRI scan of a patient where you see the compression vertebral fracture and you see the arrows where they show the sarcoid nodules. And so this is another patient, has Haberdines and Bouchard nodes and underlying dystrophic nail changes, in fact, had sarcoidosis superimposed. So the patient had a history of sarcoidosis many years back. So this is a rural area where I saw this patient. So the patient had a lack of availability of a rheumatologist. So the real detailed history was not available. We had to rely on what the patient said, was treated for chest sarcoidosis and parotid gland sarcoidosis with steroids for 6 months, and then she did not know what happened. After that, her primary care noticed that she has like bilateral synovitis and swelling and pain, but she could never see a rheumatologist until years after. So the treatment of sarcoidosis is quite standard. You know, you start with hydroxychloroquine, and some people can give you prednisone too. But then we started on a low dose of methotrexate. The dose of methotrexate was slowly titrated, which improved the symptom about 50 to 60%. And then we asked her for the next decision making, would you want to go on like the next step, biologics? And she pretty much wanted to. So by now, actually, we have given her the whole loading dose, and the next dose, obviously, is maintenance dose, and she's almost got 90% improvement in her synovitis, and she's doing pretty good. Chronic sarcoid arthritis, as I said, like typically you're going to have very much two pictures, clinical pictures can be confused with sarcoid arthritis. One is rheumatoid arthritis because it's bilaterally symmetrical. It can affect the PIP, DIP, but also the MCP joints. And it can also mimic reactive arthritis or psoriatic arthritis with pencil and cup and the distal dissolution, as well as also you can see arthritis mutilans in it, plus you can see even dactylitis in different cases. When you tap the joint, it's going to be much milder inflammatory fluid as compared to rheumatoid arthritis or the routine inflammatory arthritides. Monoarthritis is pretty rare, and differential in that would be septic and gout. So this is pretty much what we did, so I don't have to go through it, except that agents other than methotrexate can be given as traditional DMARDs, but they have not been studied well. So this is the kind of the routine paradigm. And in biologics, infliximab and Humira adalimumab have been studied the most. Second case, I think a lot of here the consultants have seen quite a bit. For the students, it's a good case. I've seen quite a few of these cases. So this was actually a nurse from a major teaching hospital from Lahore who came to see me. And she came to see me with acute onset of bilateral ankle pain and swelling for 7 to 10 days before presentation. And she had painful skin nodules in her calves bilaterally, which started almost at the same time. And on exam, she was febrile, low-grade fever, and she had acute synovitis. She almost completed the whole thing. So for the students, not the consultants, what's the syndrome called? Very good, excellent. You guys have been teaching very well, like studying very well, and your teacher's pretty good. So the lab work we still have to do for any inflammatory arthritis. ESR was high. The chest X-ray confirmed the bilateral hilar pulmonary nodules. Do we need to biopsy these nodules? And why not? This is a controversial actually topic. So yes, mostly yes, you're right. And I'll tell you the caveats of where we have to. But typically, no. So she was started on celecoxib. So in Pakistan, we do it a little differently. We have to give the patient the whole deal, because otherwise they may actually become non-compliant and they may not show up the next, what do you expect from a nurse who hardly can pay the fees, which normally we don't take actually for the patients who can't pay, but still I know the compliance is pretty poor. So along with steroids would have been the second step. We gave her from the beginning. And we tapered it off in a 4 weeks course, and she was only kept on celecoxib. She pretty much went into remission and then was lost to follow up. And that's what exactly happened with low frequency syndrome, which is basically a syndrome where you have fever, you have bilateral synovitis, joint pain, and mostly the ankles are the one which is the most affected. And along with that, you have bilateral hilar lymphadenopathy and the skin findings, which is basically erythema nodosum. Again, for the students, what is the differential diagnosis of erythema nodosum? Because as rheumatologists, we end up seeing them actually, just primary erythema nodosum as well. What are the other things? The major few things which can be confused with sarcoidosis. Sorry? Yes, that can be too. Yeah, good. What else? Yeah, very good. Keep going. So what are you missing? The big one which can mimic sarcoidosis. So TB. Yeah. So in fact, I had a patient, just digressing from the topic, who just had primary E nodosum in US for many years. After 2 years, it was basically, because skin doctors just could not figure it out. And we gave her everything, potassium iodide, steroids, NSAIDs, whatever. But eventually turned out that she had occult neoplasm and she basically had breast cancer. So anything can later on present in rheumatology, which initially is not visible. So the ESR is mostly high, but ACE levels, which is pretty much that we almost rely, which is not actually a good test at all, is only raised in about 50% of the cases. So we have to pretty much we have to rely on the rest of the clinical findings to make the diagnosis. And this is a simple chest X-ray of somebody, showing the bilateral adenopathy and the mediastinal widening, and the CT scan, which shows the multiple enlarged lymph nodes in the mediastinum in both the hilar areas. This is the typical E nodosum. Everybody knows about it. Painful, bright red subcutaneous nodule, symmetrical, and pretty much resolve spontaneously or with the treatment, and only leaves hyperpigmentation, if anything, but does not leave any scarring or any atrophy. So this is the biopsy of somebody who has sarcoidosis. We always try to take the biopsy. Where would we normally try to take the biopsy from, if anybody can tell that, if somebody is suspecting sarcoidosis? If somebody present with like an organ-threatening sarcoidosis, where would you like to try to find that? Why is history so important? Why physical examination is so important? So you always try to take the biopsy from an easily accessible area. So, for example, the best place is, recently actually had a patient which I was treating like a couple of weeks ago, and we had to actually the lymph node from the groin. So if you can have a very easily accessible place, that's where you take it from. So the underlying mechanism is same as the other inflammatory arthritis that I'll tell you that in a second actually. So sarcoidosis, I will go into a little bit in the history. History because when I was in the fellowship, the best thing I did was actually that any disease, any odd cases that I saw, I went into the library and tried to fetch the history of that original case series. And believe me, I went through everything, Schulman's disease, Paget's disease, and whatnot. And it's so interesting to find out the history. Do you guys know who Hutchinson was? And he had some Hutchinson sign and Hutchinson teeth. Anybody know about that? Speak up, otherwise I would not know. So this is the guy actually who was working hard on syphilis actually. So he was assigned, basically he was born in Yorkshire, England, and he was, and I went through that again today. He actually had homeschooling. And during those days, in the 1800s, they used to get the apprenticeship with some surgeon. So he spent some time with a surgeon and then went to the medical school, then became a doctor. And at that time, TB was a big thing. There was another thing which was going on that, TB, which has actually traced back to 150 million years, was being studied at that time because UK was going through a lot of tuberculosis because industrial revolution was going on. And the way they used to live in the factories and everything, there was this disease which was killing 1/3 of the people at that time. And it was called I think, white man's, plague or something like that. And then, so he noticed that at that time, when he became a full surgeon, then he spent time with Paget's actually. And at that time, there was all these guys, Cox, Paget's and all that, working on different kind of diseases. While he was working on syphilis, he found out that there was some patients who do not fit into routine arthritis. And there were 4 cases actually he initially studied. In fact, one I'm not presenting here is called Mrs. Mortimer, and it was called Mrs. Mortimer's disease. So there was a patient who was a policeman. He presented as gout in the MCP joints and contracted kidneys. And all the historians now going back into think that it was sarcoid kidney disease. And this actually person died from sarcoid kidney disease, assuming that he had sarcoidosis. At that time, there was another dermatologist in France. He coined a name called lupus pernio. I'm pretty sure you know this, especially the dermatologists. So why this name was, I always was perplexed. Why lupus pernio, in sarcoidosis? So at that time, actually, they used to call the skin disease of TB as lupus vulgaris. And since the flesh-like violaceous lesions on the nose look like chilblains, so they combined the days. So pernio means chilblains. So lupus pernio was the name given to that particular sarcoid skin disease of the nose. Cesar Boic, who was another scientist actually, was the one where this name is attributed to. So this is called Boic's sarcoid. He called that particular biopsy looking like sarcoma. So that's why he said, and flesh-like. So he coined the name sarcoidosis or sarcoidoid lesions. So, and then he was the one who thought that this is actually something which is multi-system. Then there's a Karl Kreibach in Prague was the first one who actually was to find out these lesions, the bony lesions we talked about. So that credit goes to him. One thing though, Cesar Boic and Kreibach and then Jungling, they were pressed hard to say that this is a version of TB and not a separate disease. So, and they gave in, although they did not believe in it. Then Swedish dermatologist, he gave it a name of lymphogranuloma benignum, then the pulmonary involvement. Now this is 1909. Hereford, who was a Danish ophthalmologist, he actually discovered that this disease can do what we call uveo-parotid fever. And there is a syndrome called Hereford syndrome, where you can have the uveitis, parotid gland involvement, fever, and cranial nerve palsies. This is a rare manifestation of sarcoidosis. And then Mucklix, we all know, describe the salivary and lacrimal gland involvement, so which means dry eyes and dry mouth. So the patient, actually our patient had that too. And then the sarcoid of the heart. I'll quickly race through the rest. One thing is very important though, that there is a genetic component which is being well studied in Europe even more than America. In fact, in Europe, there are studies available to find out the HLA predilection in the patients who actually been diagnosed of sarcoidosis. And they have different HLA-DR types to say what kind of a phenotype they're going to develop. Whether it's going to be a good phenotype or a bad phenotype, they can do the HLA typing. And the environmental exposure is very, very interesting. So there was a study done after the 9/11 in the workers fire workers and the other people who worked on the rubble and the fire and that area. And they did the study and the exposure, the quantification of the exposure, like how much intensity they were exposed to and how long they were exposed to, basically resulted in the manifestation of highly related to the sarcoid development. So there is an environmental, and mold and mildew are also thought to be very strong environmental triggers. So anybody who's genetically predisposed, if they get an environmental trigger, they're going to start developing sarcoidosis. Obesity and weight gain, another risk factor. Okay, so we'll actually have to really rush. So pathogenesis, I'll skip. Actually, it's very interesting though. I'll skip that. But primarily, when you get the biopsy, caseating granulomas and non-caseating granulomas is the main thing. Caseating granulomas is TB. Non-caseating granuloma is basically sarcoidosis. Whenever we get a chance, I can later on tell you the pathogenesis. It's really fascinating. Clinical course, I'll skip to. Skating stage is very important. Whenever actually somebody is suspected of sarcoidosis, the skating stage is done where the chest X-ray is obtained. I'll quickly skip through. Stage 1 is only lymphadenopathy. Stage 2 is lymph node involvement plus pulmonary involvement. And then stage 3 is where you have pulmonary infiltrates and not the lymph nodes. Stage 4 is fibrosis. Stage 3 and 4 are very serious. So what are you going to look for? So first, then you're going to get actually, obviously, the HRCT. When you get the HRCT, there are some things which are good prognostic markers and some are not so good. And I think all of us know about that the ground glass opacities versus honeycombing in any connective tissue disease, what do they mean? So I'm going to skip through that too. But these are the important factors to remember. Diagnosis, whenever somebody has pulmonary, so pulmonary involvement is about 90%. That's why mostly the pulmonologists were the de facto doctors of sarcoidosis. And that's why the pulmonologists are the one who are still treating it. But believe me, actually, they always lean towards rheumatologists to get the opinion beyond steroids. So you get chest X-ray, HRCT, PFTs, and DLCO. And TLC, RV, FEV1, FVC, and DLC are all reduced. It's a restrictive lung disease. Very important thing to remember, I have to tell that, is that the most important thing is that chest X-ray is not as important as these combined findings. You have to do a chest X-ray, HRCT, PFT, and DLCO because that will determine whether the lung is being affected. Whether it's even stage 1, you can still treat it. And even if it's a stage 2 and doesn't have any problem, you're not going to treat it. Which I found out actually is very fascinating, that stage 1 and 2, you don't have to really treat it until the patient is symptomatic. Now the standard of care in lung sarcoidosis is to get an endobronchial ultrasound biopsy. That is the test to do. No more opening up of the chest. This is the standard of care in USA. Very low risk, very least invasive, good yield, get it done. Treatment of pulmonary sarcoidosis, as I said, you don't have to treat everyone. Stage 1, without symptoms, you don't do anything. Stage 2, minimal symptoms, little bit of cough, give them inhaled steroids. Stage 2 or 3, severe symptoms, cough, shortness of breath, fever, all that stuff, treat them. So it's all treatment depends upon the symptom combined with all these findings. So it's not a very easy decision to treat. And stage 4 is obviously the bad one where you have to use multiple agents. So treatment is start with steroids. You continue to monitor the FVC and all the PFTs. I'm not going to go into that detail. Very interesting though, that how do you basically discuss that. And then you have to do the 6-minute walk test and everything. Keep on doing the PFTs. And then finally, if there's something is not improving, you do the methotrexate versus azathioprine. Equal efficacy. Methotrexate is safer. Azathioprine is not as safe in the studies. And then the next step is infliximab and adalimumab, which actually do work for the active pneumonitis. Refractory disease, infliximab, adalimumab. And if it's obviously fibrotic predominant, you use the nintedanib and pirfenidone. Studies are encouraging. Similarly, a very interesting pathway which is being studied is JAK-STAT signaling pathway, and encouraging early reports have been obtained. I'll skip that quickly. Neurosarcoidosis and cardiac, I really want to discuss quickly. Neurosarcoidosis is very important. So why I'm discussing the patient who really need treatment in sarcoidosis are lung disease, the kind which I mentioned, neurosarcoidosis, the kind which I'm going to quickly mention, cardiac sarcoidosis, arthritis, and skin. So otherwise, many things you can watch too. Quickly, neurosarcoidosis. If it's only facial nerve involvement, external involvement, Hereford syndrome, only maybe watchful waiting or steroid can be given. But if the brain is involved, you have to do an MRI scan. And if any part of the brain is involved, whether it's meningeal involvement, it's the brain involvement, you have to hit them hard. Similarly, cerebellar involvement, you have to hit them hard. And because they carry a bad prognosis. So you basically have to treat them. And important thing is to get a PET CT. Remember one thing, in any sarcoidosis patient, get a PET CT. Because that's the only thing which will tell you the extent of the disease. It's a very useful test to do. Cardiac sarcoidosis, very quickly, this is what carries the most important amount of mortality. Asymptomatic disease is very common. Whenever you have sarcoidosis patient, do testing. And you know, the yield is very low for ECG, Holter monitor, and echocardiogram. You skip directly to cardiac MRI and PET scan. The PET of the heart is the best test to do. PET of the heart will tell you that what part of the heart is involved and whether that patient is high risk for arrhythmia or heart blocks. So two things are very important, arrhythmias and heart block. So arrhythmia is very important because you have to do the no, actually, I lost the train of thought. But anyway, if you have the gadolinium, which is positive, enhancement is happening, you have to give them steroids and also give them all the immunosuppressants. Other thing is very important is the congestive heart failure. So if ejection fraction is low, less than 35%, not only that you give everything else that I mentioned about all the standard treatment, steroid, methotrexate, infliximab, or whatever, you have to treat them according to what you treat congestive heart failure with, plus you have to place an ICD. These patients die from certain arrhythmias, VFib, VTAC, and heart blocks. Cutaneous sarcoidosis, I'm going to quickly skip through that. Treatment of cutaneous sarcoidosis, if localized lesion, only give localized steroid injections. If multiple lesion, you give steroids. If beyond that, you can use infliximab, adalimumab, and thalidomide. Ocular sarcoidosis is almost my last one. Ocular sarcoidosis is any part of the eye can be involved. In fact, it's very interesting. Anterior uveitis is less risky. Posterior uveitis is very serious. Treat posterior uveitis. Now, important thing is posterior uveitis is not that symptomatic, only vision loss. It can be painless. Interior uveitis is very dramatic, more painful, but less long-term consequences. And chronic uveitis, even interior, is where we see the mutton fat KP is very important. I'm going to skip through the rest. These are the mutton fat KPs. You see the involvement of the conjunctiva and palpebra. And this is the slide on the right side is very important because that is retinal vasculitis. which is basically sarcoid vasculitis with candle wax dripping. This is very important because there you hit very hard because they can have neurological complications too. So I'm going to skip through the rest. Very interesting was renal. I can discuss it in another forum. Almost like another 5 minutes is needed for renal. Very interesting how hypercalcemia happens, how to manage hypercalcemia, who to screen for hypercalcemia, and how the stones happen, and what can happen, even a GN. So sarcoid is the greatest mimicker along with syphilis. It can affect anything and any organ. So that's why I said PET scan, good history, good physical examination is extremely important. So multi-system disease, great mimicker, once suspected and diagnosed, intense baseline investigation, and work up to see the extent of the disease. Pulmonary involvement is the most important. Treatment mostly requires a multidisciplinary approach, and that's it. Thank you very much. Sorry I had to rush through the slides. Very interesting. If ever you give me a chance, there's a lot more actually I could speak about. Sorry about the timing. Any questions I can answer now. I don't know what the protocol is. Okay? All right. Thank you.
Thank you, Dr. Qureshi. The next speaker for the session is Dr. Javed Malik, who is a rheumatologist and medical specialist currently practicing at Rahmat Noor Clinic, an arthritis research center. I'd like to invite Dr. Javed onto stage to discuss Sjogren's and the hawk-eyed rheumatologist.
Thank you very much. Thank you to the organizers of the 25th PSR. It's a really great honor to be present in the first ever PSR 25 years ago, myself, Abid, and a few others. And we hope to keep going for next 25 years and more, inshallah. I must say, this conference has set the bar so high that the future conferences will have to work very hard to come to the standards that have been set here. I've been tasked to talk about Sjogren's. It's a big topic, and I may be struggling like Shakib did to cover in 20 minutes, but let's start. Basically, it's an inflammatory disorder of lacrimal and salivary glands primarily, which present with dry eyes, dry mouth, and enlarged glands. But other symptoms like fatigue, arthralgias or even arthritis, skin rashes, and multi-system involvement may be there. And the serious consequence in a minority of patients is lymphoma. We'll be discussing primary Sjogren's syndrome. Secondary is associated with other connective tissue autoimmune diseases. And the systemic complications occur in 30 to 40% of patients. But three principal symptoms: dryness, eyes and mouth, fatigue and pain. These are the three. And these are the three areas of focus of treatment as well. The lymphoma risk is 5 to 7 times higher as compared to general population. The incidence is interesting, is about 6.9% per 100,000 years, and prevalence is 60 per 100,000. But if you compare region-wise, in South America, Latin America, there's higher percentage of females versus Europeans and North Americans. The age of onset is younger, and they have lower incidence of hypocomplementemia and higher percentage of rheumatoid and lupus and so on. Whereas compared to the Asian population, this is data coming from Colombia, their ages are later than the Asian population, and a lower percentage of pulmonary involvement, and antibodies are lower as compared to Asians. The sicker symptoms relatively in the cases reported from China, India, and elsewhere are slightly less than the Caucasians and Hispanics. But there is higher reported frequency of lung involvement, both interstitial lung disease and pulmonary hypertension. Renal tubular acidosis and other renal disorders affect about 6 to 16%, depending of which study you look at. And there's a much higher frequency of antibodies to anti-nuclear antigen, anti-Rho, anti-muscarinic receptor type, alpha, fordrin and antibodies. And it is a multi-system disease. Besides the Zika symptoms, constitutional symptoms, lymphadenopathy, CNS involvement, joint involvement, rashes, skin, myositis, or peripheral neuropathy. And there are various percentage, and this is a big group, international Sjogren's cohort, and they publish their findings every few years at the ACR or the ULR. And this is coming from the 2017 ACR. Now, the other point here of interest, or for us treating clinicians when we are following it, who are at risk factors at risk of developing lymphoma. There are those who present with recurrent swelling of parotid glands, those who have splenomegaly, lymphadenopathy, or both, presence of purpura, a score of more than 5 in disease activity index, which I'll explain in a minute, presence of rheumatoid factor, cryoglobulinemia, low complement levels. These are all risk factors for future development of lymphoma. Presence of ectopic, and on biopsy, there are certain characteristics which a focus score of more than 3, or certain germinal mutations of TNF-alpha associated proteins. So these are all have been noted and reported as risk factors for developing lymphoma. More recently, there were 2002 diagnostic criteria of a consensus group of America and Europe, and they have been more recently in 2016 replaced by the classification criteria of ACR and ULR, and with the weighted scores. So the scoring is that if there is on biopsy labial or salivary gland lymphocytic sialadenitis and focus score of more than 1, that gets high score. Presence of anti-Rho antibodies gets a high score, and also ocular staining, positive Schirmer test, or reduced salivary flow rate. I'll explain all these in the coming slides. And it's certain inclusion criteria. This is a questionnaire that the clinicians or the rheumatologists ask the patient that if you had daily persistent troublesome dry eyes for more than 3 months, and do you have a recurrent sensation of sand or gravel in the eyes, do you use tear substitute more than 3 times a day, daily feeling of dry mouth, frequently drinking waters, or suspicion from a disease activity index questionnaire, at least one domain. So even if one domain is positive, then it raises the possibility. And these are the exclusion criteria, that if any history of the head and neck radiation, chronic hepatitis C, AIDS, sarcoid, amyloid, IgG4, graft versus host disease, so then this questionnaire doesn't apply here. Now, going on to this classification criteria, the same group who participated in it, they look, a year earlier in the UK, they published that this is where the hawk comes in the title, that those patients who were diagnosed at rheumatoid arthritis, but they had, on the basis of rheumatoid factor or lupus or scleroderma, they went back and they applied these criteria and questionnaires with the presence of Zika symptoms. And out of, like, for example, out of a total of almost 200 rheumatoid patients, 72 fulfilled the criteria of primary Sjogren's. Out of a total of 165 lupus patients, nearly 1/3 filled the criteria of Sjogren's syndrome, and so on for scleroderma, and with people with 2 or more autoimmune diseases. So it is something which gets missed because you rely on the antibodies and then you just label it as rheumatoid or lupus or perhaps scleroderma. But when the other characteristics are in the picture, in the clinical scenario, favor Sjogren's, then perhaps we shut the case. Okay, fine, this is it. But if you go deep into it, and maybe it becomes obvious that we are dealing with a primary Sjogren who happens to have a positive ANA or rheumatoid factor. Now, this is in the next few slides, there have been clinical trials of treatment in primary Sjogren's, and these were the instruments used to report the results. And one of these instruments is the patient self-reported index, and it asks questions on dryness, fatigue, and pain on a scale of 0 to 10, and the total cumulative score is 3, and any score of more than 1 is considered significant. Similarly, these are the disease activity index with different domains, and total score is about 123. Different weightage given to depending on the organ involved, and a score of above 13 is considered highly active, and score of more than 5 is considered moderate activity. Now, once we got a patient whom we have diagnosed, the first thing is to confirm the diagnosis, assess the activity and severity, and then determine what is the disease subset. Now, diagnostic evaluation asks about dry eyes, dry mouth, enlargement of salivary gland, absence of saliva, dental caries. Note here in the slide, the caries is involved in the incisors. That is typical of Sjogren's. And filiform papillae in the hyperlopilated tongue. And they may have purpura or evidence of neuropathy. Now, to absolutely confirm is to do either a Schirmer test or abnormal staining, document salivary hypofunction, or an ultrasound or MRI of the parotid glands, or serologic tests, or even to the extent of doing a salivary gland biopsy. And I'll just quickly go through all of these. So the Schirmer test is you put a strip in, and normally people would stain that strip for more than 10 millimeters, but less than 5 is significant. Staining of the eye can be done with fluorescein, lissamine, or rose Bengal. It will tell you the area which is denuded and which is dry, and that confirms presence of dry eyes. And this is an instrument which is used in clinical trials, depending on which dye you use. It's a scoring sheet, and it looks at the number of the points or the stains or the dots in the different regions of the eye is given a score, and that score is then re-evaluated in 3 or 6 months' time after giving some treatment. The assessment of salivary hypofunction can be done, apparently looks very simple. Whole salimetry, this unstimulated, is you ask a patient to expectorate once and then collect all the saliva in a pre-weighted. So you have a container, you wait, you after 5 to 15 minutes, you ask whatever the saliva that comes in the mouth to wait, and and then the container is weighed again. It's normally 1 gram per ml. A collection of less than half 0.1 ml per minute is indicative of abnormal salivary function. Looks simple enough to be done in a clinic by one of the nurses or somebody you can train. And the Saxon test is again utilized. It's a pre-weighted gauze, and the patient holds it in the mouth for 2 minutes without swallowing. And pre and post, you weigh the sponge, and the weight it should increase by 2.7 gram. If it doesn't, then it confirms or documents salivary hypofunction. Ultrasound is a useful test, and in the middle you can see calcification here, and that correlates with the site of inflammation. This is normal. So specks of calcification on ultrasound of the parotid will confirm or highly suggest the presence of inflammation in the parotid gland, and this has been borne out by this study which showed sensitivity of 67% and specificity of 94%. So it's a good test to do, and now we have interest in ultrasound, and maybe that can be performed again. And sometimes even MRI may be done, which shows specks of calcification in the parotid glands. So these are all useful tools when we are in doubt to go ahead and confirm our diagnosis. Antibodies are well known, anti-Rho, 60, 52, and anti-LA. Also ANA, rheumatoid factor, anti-CCP, anti-centromere, and other antibodies. The important thing is it's been reported in literature these antibodies may be present in the serum 3 to 4 years before actually the patients manifest. The salivary gland biopsy is an OPD test, and the biopsy will show, this is a normal gland, focal areas of inflammation. And so basically the focus score I was referring is you need at least 4 lobules, and you should be able to document lymphocytic sialadenitis, and a 4 millimeter square surface area shows a focus score of more than 1. And you need at least 50 or more mononuclear lymphocyte cells in that area to say there is sialadenitis. Other investigations, complement levels, electrolytes, immune electrophoresis, cryoglobulins. As the subset patient are really sick, these are the sick ones, CP, SR, CRP, and so on. Assess for proteinuria, assess liver function, assess kidney function. So this was the first part, was the assessment. Coming to the treatment. There are some certain simple treatments for dry eyes. That's avoidance of aggravating medication. And medications, especially in the elderly, are an important cause of dryness of eyes and mouth. So these are drugs with anticholinergic side effects, sometimes antidepressants, antipsychotics, so on. So that's about the wearing of large frame glasses. Environment should be not too dry. Warm compressors, humidifiers, and one risk is during patients going for surgery, intraoperative care, and use of artificial tears. The choice of and composition of artificial tears is multiple, and they're all been included in the various recommendations that we see. We usually have 2 or 3 preparations available here in the country. These days, even those are in short supply due to COVID. So, but still, we have 1 or 2 agents in the market. For severe disease or refractory ocular dryness, it's obviously not the domain of the rheumatologist. These patients will go to the ophthalmologist, who may consider a short course of topical NSAIDs or corticosteroids. Topical cyclosporin has been approved, serum tear drops, and there are certain other rescue therapies like plugs, and oral muscarinic agents have also been used. And they need to be, even if they turn up in the clinic and haven't been to their ophthalmologist, we need to emphasize that they should again go back to their ophthalmologist and not ask for the treatment of their difficult eye condition. For the dry mouth, simple measures like good hydration, oral desiccants to be avoided. Again, medication is an important source of dryness, and then the ones which make it worse should be avoided. Open nasal passages, low humidity environments, salivary stimulants, and avoiding acidic drinks. And some simple, measures are useful, like sugar-free candies or lozenges, sugar-free chewing gums, topically applied oral inserts can be used, citrus-flavored sugarless tablets, and one thing which I find I like to is to go ask them to just chew on some dried peaches or nectarines and dry fruits for a short while. Too much of that, obviously, yes, they need to avoid sugar candies because that will lead to caries. Artificial salivas are there. They've been studied. They've been studied, and there have been small trials, and they all get a mention. And one preparation is available here in our country as well, of carboxymethyl cellulose. There have been clinical trials and reports of oral agents to stimulate salivary secretions. To some extent, they have been useful subjectively, not objectively, for ocular dryness, pilocarpine and cevimeline. They all have side effects like sweating, flushing, nausea, and diarrhea. One important thing is the treatment of salivary gland enlargement, which require, if it is unilateral, hot compresses, analgesics, major involvement, suddenly very painful, short course of steroids. If there is persistent enlargement for over 3 months, then these have to be evaluated for lymphoma. For the musculoskeletal symptoms, NSAIDs and then methotrexate and leflunomide, there are no clear guidelines. You treat, if it is arthralgia, you would treat it just with NSAIDs, but if it is frank arthritis, more than 5 joints, that's rare, and you need to use one of these agents. The other aspect clinically is fibromyalgia and fatigue, which affects about 40%, and you need duloxetine and pregabalin are the agents one can use. But important thing is to look for if they are cause of their fatigue is either anemia or hypothyroidism, depression, or some vitamin deficiencies or disturbed sleep. So it's not just fatigue, it's not just, there may be some other reason for their fatigue. Specific therapeutic agents, primarily by and large, corticosteroids historically have been used as the treatment in primary Sjogren's, although it is said that they should be used in lowest possible doses for shortest possible time. But still, if you look at it, a lot of patients, more than 50%, are taking low doses of prednisolone. And other agents which are here in the list are mainly as steroid-sparing agents. So there's nothing to choose between one or the other. Hydroxychloroquine is the go-to drug for us rheumatologists, and we tend to like to use it for arthritis and other symptoms, although the guidelines do not recommend it for oral dryness. But any of these agents can be considered as a glucose, depending on which organ is involved, as a steroid-sparing agent. It is a B-cell mediated disease, so drugs which act on the B-cell or the activating factors or the receptors or co-stimulants, they've all been studied in various clinical trials. The two trials are TERRORIST trial and practice trial of rituximab. Unfortunately, they were negative, but historically, rituximab continues to be used for interstitial lung disease associated with cryoglobulinemia and so on. So it is the go-to drug, but it doesn't, the clinical trials have not been that helpful. And other therapies they've been studied. Belimumab has the one trial they had, it showed a positive trend, but it did not receive, maybe in subset there was some significance, but it did not give a good result. Abetas similarly is the story for abatacept. It has been tried, but the result, primarily they were looking at the oral and the ocular dryness and fatigue and pain. And that was those were the endpoints, and there was no change between the control groups and the treatment arms. Recently, I know that there's a trial going on of tocilizumab in Sjogren's, but we wait for its reports. And finally, there are recommendations in the management from the British Society for Rheumatology and also the EULAR. And there were 3 overarching principles and 12 specific guidelines. And basically, these are the overarching principles that patients should be managed at centers of expertise with a multidisciplinary approach. The first therapeutic approach to dryness should be symptomatic using topical therapies. And systemic therapies may be considered for active systemic disease. And I've gone through all of them in my previous slides. So in the end, it is like for all these multi-system disease, you need a multidisciplinary team approach. So you need a maxillofacial surgeon, an ophthalmologist, and a rheumatologist. And non-pharmacologic and preventive interventions, emphasizing them, educating the patient, play a big role. Mild Sjogren's syndrome with Sika alone, without glandular involvement, doesn't do much and is not that challenging. But those with moderate to severe disease, with glandular involvement, with extraglandular, those are challenging patients, and they require constant monitoring and follow-up. So I thank you all for your attention, and we'll be happy to answer the questions that you have.
Thank you, Dr. Javed Malik. Next, we have Dr. Beena Hamid, who is a consultant rheumatologist and internist currently practicing in the UAE. Please welcome Dr. Beena Hamid onto stage to speak on anti-rheumatic drugs in pregnancy.
So thank you very much again. Thank you. So I'm very well aware that this is we are all in postprandial status, so it's really difficult to absorb the information I'm going to give you all, but I'll try my best to make it as easy as possible. So no disclosure again. So the objectives of this talk is to understand the pregnancy outcomes in the rheumatic diseases, understanding safe prescribing of anti-rheumatic drugs in pregnancy, and overall how to manage rheumatic diseases in pregnancy. So these are few studies for 3 most important conditions that we see, and we all know that rheumatic diseases are prevalent in women of childbearing age, and not all the drugs are safe. So I think it's important, first of all, to know what's the impact of pregnancy on rheumatic diseases. So there are 3 things we consider. One is there any risk of flare of the rheumatic condition during pregnancy, or what's the maternal or what is the fetal risks involved. So talking about rheumatoid arthritis, previously it was a notion that the rheumatoid arthritis eventually is in remission as the pregnancy advances, which is not true anymore. because the recent studies have shown actually good 1/3 of patients do flare during pregnancy, needing ongoing treatment. The maternal and the fetal risks are rare. Ankylosing spondylitis, 1/4 do flare, and again, good news is there's no maternal and fetal risks. The main problem comes with the systemic lupus erythematosus, where half of the patients do flare during pregnancy, in particular those who haven't been well controlled before conception. So the maternal risks include miscarriage, preeclampsia, and prematurity, and the fetal risks are intrauterine growth retardation, prematurity, and neonatal lupus. So pregnancy, poor outcomes, there are a few factors you have to consider at preconception stage to see whether a woman should get pregnant or they should wait or not. So certainly in systemic lupus erythematosus, if a disease is not being controlled for 6 to 12 months before conception, there's a problem. And if the serological markers such as double-stranded DNA is raised, complement levels C3, C4 is low, and that certainly is associated with increased risk of flare and also obstetric complications in pregnancy. Lupus nephritis as such, whether it's an active lupus nephritis or patients who have had lupus nephritis in the past, constitutes a risk. The presence of anti-Rho and anti-LA or SSA, SSB antibodies is very well known that is associated with neonatal lupus, including congenital heart blocks. Antiphospholipid antibodies, there's a risk of thrombosis, increased pregnancy morbidity, and especially if patients have a previous poor obstetric outcomes. And people or patients who have had organ damage already related to the disease, and often it progresses. So what are the challenges? The challenges are that rheumatic diseases, we know that we come across with poor pregnancy outcomes, and most of the drugs actually transfer through the placenta, and we don't know about the long-term effects of these drugs, and most of the safety data comes from case reports or from the registries, because it's not ethical to perform the clinical trials or comparative trials in pregnancy, and the data from the animal studies cannot be extrapolated to the humans. So here's a list of commonly used anti-rheumatic drugs, and I'm going to talk about them. So in terms of risk stratification, you can divide them into drugs which have minimum fetal effect or maternal risks, which essentially means you can use them during pregnancy. Then there are certain drugs which are allowed as selective use, which essentially mean that they can be used in a controlled dose and also in some period during the pregnancy, not the whole pregnancy. Then there are drugs which carry moderate to high risk, which can harm the fetus, and certainly you tend to avoid those drugs during pregnancy. And then lastly, there are drugs which have a limited data, and essentially, as you don't know about them, so it's not safe to use them. So here's a list of medications which are sort of safe during pregnancy. And these are mostly your hydroxychloroquine, sulfasalazine, azathioprine, cyclosporin, colchicine, and aspirin. But it's a low-dose aspirin, they'll say, because teratogenic effects are not seen often, and it's less likely to cause stillbirth, spontaneous abortions. Then the other thing is lactation. It's important to know that once the baby is born, most of the women, they would like to breastfeed their children. So generally speaking, these drugs are also safe for the breastfeeding purposes, apart from sulfasalazine. If an infant is premature and would have hyperbilirubinemia or have a G6PD deficiency, certainly it's a difficult decision because sulfenpyridine, which is a metabolite of the sulfasalazine, it has been seen in the breast milk up to 40%. Apart from that, other drugs are pretty safe. Then there are drugs which can be used, but then again, you have to be careful about the dosage and also at what time of pregnancy they're permitted. For NSAID, the preferred drug is ibuprofen, up to 1,600 milligrams per day in lactation, but pregnancy point of view is difficult. Any NSAID which you use beyond 20 weeks or 30 weeks, there is a problem because we do see the infant renal impairment, and then, of course, there is a problem of risk of premature closure of ductus arteriosus. For that purposes, third trimester, you tend not to use them. Cyclooxygenase inhibitors, there isn't much data. Corticosteroids can be used during pregnancy. However, you have to be careful about the dosage. Most of the guidelines and the studies would mention you should limit its use 15 or 20 milligrams per day, because if you go above these doses, there's always risk of maternal complications such as diabetes, hypertension, osteopenia, preterm, premature rupture of membranes, and the fetal risks such as oral cleft, growth retardation, and prematurity. And in terms of breastfeeding, so one should avoid breastfeeding at least for 4 hours after the last dose of prednisolone, because then it's less likely to pass into toxic amount for the fetus. Anti-TNF, the safest is certolizumab because it lacks the FC portion of the antibody, which is responsible for the placental transmission, so that's probably safe throughout the pregnancy. Then is etanercept also been regarded as safe because it's also not been seen in larger amount of placental blood. However, the monoclonal antibodies, infliximab and adalimumab, because they are present in higher amount, so certainly it is limited to first and second trimester of pregnancy. And the other problem is the vaccination. The infants who have been exposed to anti-TNF, it's recommended that they shouldn't receive any live vaccine during the first 6 months of their life. Intravenous immunoglobulins, as they pass on in a significant amount to the fetus, so after 30 to 32 weeks of gestation, so it should be limited before that. As such, the anti-TNF safe in breastfeeding because they are larger molecules, they do not express in the breast milk in a larger quantities, and so is the intravenous immunoglobulins. Cyclosporin, the transfers to the fetus in the third trimester has been seen, but so far there's no human teratogenicity seen, and the breastfeeding data is conflicting. Tacrolimus, there's a problem with prematurity. However, the breast milk expression of the drug is safe. So moderate to high-risk drugs are cyclophosphamide, methotrexate, mycophenolate, and leflunomide, because all of them, they are associated with teratogenicity. In terms of breastfeeding, cyclophosphamide is toxic in the breast milk, so baby shouldn't be breastfed. Methotrexate, because it's transferred in a very small amount, breastfeeding can be allowed, and then rest, there's no much data. So here's a list of medications which we have a limited data, and most of them, they are known anti-TNF biologics, and the small molecules, the JAK inhibitors, tofacitinib. And pregnancy, it's because limited data, so best not to use during pregnancy. Otherwise, abatacept has a large molecule, secukinumab, izokizumab, tocilizumab, and ustekinumab. They have a larger molecules, so the breastfeeding is permissible if a patient is on them. And certainly, tofacitinib is a small molecule, so the baby shouldn't be breastfed. So bisphosphonate, there are only animal studies, and which has shown that there's decreased bone growth in offsprings exposed to the drug, and it can cross the placental barrier. However, as such, there isn't much reports on toxic effects, but the recommendations as by British Society of Rheumatology is to stop 6 months before conception. Anticoagulation, heparin is safe throughout the pregnancy. Warfarin has a teratogenic effect, you don't want to. And novel anticoagulants, there isn't much data, so you tend to avoid. So I just wanted to compare the 3 guidelines. We have ACR 2020, which is the latest. Then you have EULAR and BSR 2016 guidelines. And as you know that we have more and more data, the guidelines also change. But this is basically guidelines for pregnancy, breastfeeding, and parenteral use. So you see your prednisolone, all 3 guidelines would agree that you can use in a moderate dose prednisolone 15 and 20. But if you go above that, there are risks. Intraarticular and intramuscular steroid injection is fine. Even methylprednisolone in 2016 EULAR guidelines, they say it's okay to use in case of emergencies. Fluorinated glucocorticoids should not be used because obviously they do cross the placental barrier in larger quantities, whereas prednisolone is partially degraded by the placental 11-hydroxylase enzyme, so that is safe. But one of the advantages of fluorinated glucocorticoids is because it passes on to the placenta in a larger amount, so it can be used for the fetal purposes where you want to treat the baby for neonatal lupus. Then colchicine, again, it's safe throughout as per ACR, all three occasions, pregnancy, breastfeeding, or parenteral use. And EULAR would say not up to 1 milligrams is safe. NSAIDs can be given first and second trimester, and that's agreement throughout all the three guidelines, but avoid in third trimester. COX-2, there's no data. For the conventional DMARDs, your hydroxychloroquine is a thiopurine, sulfasalazine is safe. However, with sulfasalazine, you have to supplement the woman with 5 milligrams per day folic acid because sulfasalazine reduces the absorption of folic acid from the gut and also interferes its metabolism. And we know that the growing fetus needs folic acid. Methotrexate, all three guidelines say 3 months before conception. And we just saw before that the breastfeeding is okay. However, in the guidelines, if you look at the 2016 guidelines, they say no, not to breastfeed. Whereas if you see 2020 guidelines, ACR, it says conditional, right? It's limited, this still said limited data, but the other studies show because it's not expressed much, you can allow them. Leflunomide, as you know, leflunomide has a half-life is of almost 2 years, so it's difficult. Even if you stop, you can't get rid of the body for 2 years, so cholestyramine washout is important. Even when you give cholestyramine washout, you have to do the levels, and the levels, when they are, I think, more than 0.02, then you have to repeat the washout. Mycophenolate, all three guidelines would say stop 6 months before conception. Calcineurin inhibitors, cyclosporine and tacrolimus, they are considered safe for all three reasons. And cyclophosphamide, they would say stop 3 months before. However, in third trimester, if there is no option and it's a life and death matter, you can still use them. Because most of the organogenesis happens during the first trimester, so probably in a desperate situation, you are allowed to use. Then thalidomide, again, there's only guidance from ACR that should be stopped 1 to 3 months before conception. So there's a data, basically what I said already, that apart from certolizumab, which can be given throughout the pregnancy, the rest one should stop at the third trimester of pregnancy. And of course, breastfeeding is fine. Abatacept, no data. But by ACR guidance, there is some data that they say conditional for during pregnancy. So rituximab, stop 6 months before, but then only if there is a life-threatening situation where there's no other option, you can still use it. Belimumab, no data, and tocilizumab, stop 3 months before. So it's really important to provide women a pre-counseling even before they get pregnant, and that's the routine clinical practice. When we start a younger woman on any of these drugs, we do discuss with them in detail the problems with the conception. So, but here are a few things that you have to be careful, and you should rather counsel the woman against pregnancy if they have severe pulmonary hypertension, restrictive lung disease, advanced renal insufficiency, advanced heart failure, because then mortality is quite high. And if they have a previous severe eclampsia or HELLP syndrome, despite being on a good therapy, and if they sustain a stroke 6 months before they decide to conceive, and if they have a severe flare of the disease in the last 6 months. So fetal complications, anti-Ro, anti-La antibodies, we know that it is associated with neonatal lupus. 10% infants, they present with classical rash, 20% had transient cytopenias, and 30% would have mild transient transaminitis. they usually resolve as the maternal antibodies clear from the infant. The complete heart block incidence is about 2% in a woman who never had the baby with neonatal lupus. However, in the subsequent frequencies goes as high as 18%. And usually the complete heart block is irreversible, and it's estimated 20% of those affected die in utero or during the first year of their life, and over half of them require a pacemaker. So what to do with these patients during pregnancy? So obviously, if a woman has these antibodies, I think it's really important if you do have a facility where you have obstetrician with the neonatal expertise, you should better manage these patients with the help of them. Because if they do have these antibodies, these women need regular fetal echocardiogram between week 16 to week 18. And if they have a history of previous neonatal lupus baby, then it should be done at least monthly. And they should be on both whether they have had a baby before affected with neonatal lupus or not, should be on hydroxychloroquine. If you do detect that the baby has first or second degree of heart block during pregnancy, so it's worth giving them dexamethasone 4 milligrams a day. However, if there's an established third degree heart block, it doesn't work. Then equally important is postnatal care for these women, because we do see that these patients often flare in postpartum period. About half of the rheumatoid arthritis patients, about 90% including spondylitis, again up to half psoriatic, and up to 70% systemic lupus erythematosus patients. Can I have some water, please? Some water. So certainly it's seen that if there's a seropositivity, if the disease has been uncontrolled pre-conception, that increases the risk, or a TNF has been stopped prior to conception, the risk goes very high. And in terms of antiphospholipid antibody syndrome, there is 2 to 10-fold increase in thrombosis, so you have to really monitor these patients. And there is some guidance that you might consider giving them anticoagulation postpartum. Thank you. So it's seen that most of the rheumatic diseases, they flare within the first 3 months of postpartum, so you have to be carefully monitoring them and start them on treatment as soon as possible. And of course, we have to be carefully select the drugs and advise the woman whether they should or shouldn't breastfeed, or whether they need to change the medications, which are feeding friendly. Then often we are asked this question as a rheumatologist from many other specialties. If the patient has been on biologics, when to safely start them back on postpartum. So generally speaking, if there's no risk of infection and a baby is born by a normal vaginal delivery, you can start them as early as within 24 hours. Whereas if a woman has gone through a cesarean section, you start within 48 hours. And the rest is immunization. Non-live immunizations is fine for the baby. However, if somebody has had, like I said before, exposed to the anti-TNF, you have to wait for at least 6 months. And the vaccinations which are planned at month 12, you can carry on with them. So in conclusion, it's all about planning pregnancy in advance. You reassess and you monitor your pregnancy timely. And if you give them optimum therapy and the selective therapy, usually the outcome is good. And then postpartum care is also important. And I think I finished in time this time. Yes, thank you. Thank you.
Thank you. Thank you so much, Dr. Beena, for such an excellent talk. Our next speaker for today is Dr. Daniel Seger. He is a rheumatologist and affiliated with Providence Hospital, Hood River Memorial Hospital, and Providence Portland Medical Center, and he would be speaking on his experience with JAK inhibitors.
Assalamu alaikum. Thank you so much for this opportunity to be with you today. My sympathy to the people of Pakistan for the recent difficulties in your country with the flooding. And it's a little bit ironic to come here from the United States. We're responsible for a lot of the carbon emissions, as you know, and whereas Pakistan is not responsible for a very high percentage. I don't know if I can apologize on behalf of my country, but we have a lot of work to do in our understanding our global community. But it's a pleasure to be here. I want to acknowledge my Lahori friends and colleagues who have now worked hard for many years to bring this conference and rheumatologic care to the people of Lahore. And I want to thank the co-conveners for their excellent work and all their help in getting me here to Lahore. My understanding is that Haranis Pharmaceuticals is a generous contributor to the meeting, and that provides for assistance, travel assistance, or other expenses for your visitors who speak here internationally. So I'd like to disclose that that is also involving me. I'm going to be talking about tofacitinib from my own perspective. Everyone has their own perspective, and so you need to take that into consideration as you hear my comments. But I want to ask the people in the room, if you could raise your hand, how many of you have prescribed tofacitinib to a patient with rheumatoid arthritis? And then keep your hand up if you've prescribed it to more than 5 patients with rheumatoid arthritis. How about more than 10 patients with rheumatoid arthritis? How about more than 15 individual patients with rheumatoid arthritis? Numbers are going down. Let's just jump out. How about more than 30? My hand goes down. Hands are still up. Okay, so they say an expert is someone with 15 minutes more experience than you have. If one person has prescribed one patient more than I have, then you should be up here giving the lecture instead of me. But I'm the invited speaker, so I'll talk about my patients. I think I have 15 patients with rheumatoid arthritis on tofacitinib presently. Some may have fallen off. So, you know, this is not a drug that I'm using heavily, and I think that reflects the fact that we have a lot of options in the management of rheumatoid arthritis in the United States. Tofacitinib is one of the hardest drugs for us to get insurance coverage for. My understanding is Haranis is making this available to the people of Pakistan for maybe as little as $80 US a month, which is a lot for many of your patients, maybe clearly unaffordable for even the majority. But in the United States, it's $5,000 per month. So $80 versus $5,000 per month. You can see that I'm not prescribing this to a lot of people for a good reason. But we have lots of options now in treating rheumatoid arthritis, including tofacitinib, which is an indirect mediator of cytokine function. We can use abatacept to inhibit cytokine mediation, and we can deplete B cells. So, you know, there's competition for new products. Tofacitinib, being an oral agent, has some advantages. It can be produced through traditional mechanisms, not extremely high tech. It has a unique mechanism of action, which leads us to be cautious as much as it leads us to be optimistic that this might be a substantial development in our treatment options. And this has been shown to be comparable to TNF inhibitors in limited numbers of studies. So tofacitinib is certainly here to stay, and the other JAK inhibitors that will be competing with it are here to stay, and I think it remains to be determined exactly what role they play in the long term. I like to call etanercept a revolutionary drug. I was involved with a clinical study in 1997, just before it became available to rheumatologists in the United States. I was the blinded investigator in one center for the original publications of etanercept when it was a small biotech company in Seattle, Washington. And even though I was the blinded rheumatologist in this study center, it was really clear who was on this drug and who wasn't among the patients who were in the study. So the typical patient would say, I'd say, how are you? And they'd say, like that. And then I'd ask the next patient, how are you? And they'd say, oh my goodness, I haven't been like this ever with my rheumatoid arthritis. So, this was a dramatic advance. And the point is tofacitinib going to be a dramatic advance? I think that remains to be seen. Infliximab I call socialized medicine because in the United States this is covered, the majority of the cost of infliximab, because it's given intravenously, is covered by Medicare government insurance for people over the age of 65, whereas it's still difficult for them to get on the subcutaneous injectable biologics. So I like to think of etanercept as revolutionary and infliximab as socialistic, and then adalimumab as capitalistic. The best-selling drug ever made on the planet Earth is adalimumab. So, you can make money with these drugs. These are expensive drugs. They're really useful. And adalimumab came along subcutaneous every 2 weeks to compete with Enbrel, which was subcutaneous twice a week, and really captured a lot of the market. And then there's the Me Too's. A lot of Me Too drugs that you could say are really not that different maybe than the rest of the biologics in terms of their benefit and risk. And then two new things, the B-cell drug rituximab, which I like to think of as living in the brave new world, to reference the dystopian novelist from the UK, Aldous Huxley, wrote a book called The Brave New World. I mean, depleting people's B cells dramatically in the COVID era is brave. You have to be brave because they're not going to respond to their vaccines. And there are ways around that. There are technologies now to help those people, but I think this is still a brave technology. I have lots of people on rituximab. It has a role. And then the JAK inhibitors, as I've mentioned. So one patient at a time, very different than clinical trials and p-values and things of that nature, right? So everyone out here in the audience has an experience like me. In the US, our experience is heavily influenced by the patient. The patient reads about or hears about these things on television. They come in with preconceived ideas. And so we have shared risk assessment with patient-centered care. And then, of course, medical insurance. And then, as an individual, we all interpret the clinical trials data differently. So we have a very individualized experience, to make that point. So in giving you these case examples today, you have to keep in mind that I have potential bias as a speaker. One type of bias is my ascertainment bias. I'm sort of choosing which cases I present to you. You could say that, cases that stick in your mind, that have more educational value in your own personal practice, you could call those peak events. They sort of outweigh the mundane experiences of the average patient. And then there's confirmation bias. Anytime you give a talk, you have some, incentive to make your point, and that's considered seeking confirmatory evidence for your point of view. Let me start with this young man. I'll give you his initials, JP. I first saw him when he was an 18-year-old high school student in 2011. He was a runner, very active athlete. He had had 2 years of tender swelling in the wrist, which of course was explained as something like an injury, but then things had progressed. He had an interesting background of Achilles tendon surgery and a rash on his hand and a childhood eczema, making me think he might have psoriatic arthritis. But he had no sign of psoriasis at the first visit. He did have features of inflammatory disease, as shown here, including maybe a dactylitic joint, like you would see with a spondyloarthropathy, like psoriatic arthritis or reactive arthritis. But his serology was consistent with RA. He had probable erosion on x-ray, and so we have been treating him as a rheumatoid arthritis patient. This was his original treatment, good old-fashioned sulfasalazine and NSAID, and we injected 3 or 4 joints, and he did reasonably well, but only for a short time. 3 months later, things were bad enough. His loss of function was dramatic enough. He went on a biologic, and then continued sulfasalazine. And then 5 months after I first met him, the sulfasalazine was considered ineffective. He was switched to methotrexate, and the TNF inhibitor was continued. However, by the 4th and 5th year, he was doing poorly despite TNF inhibitor and sulfasalazine, or methotrexate, and so he went on to leflunomide and switched stopped his TNF inhibitor and had to take prednisone. By the 6th and 7th year, he was on rituximab briefly, just desperately trying to control his disease. And then he told me, I'm moving to Argentina. So you don't take intravenous drugs, or you don't easily take subcutaneous biologics to Argentina with you. So Xeljanz was on the scene in Oregon, tofacitinib, and we put him on that. Subsequently, the take-home point for this one patient is he did remarkably well, continuing leflunomide with the addition of tofacitinib through the present, being able to stay off prednisone long-term, hardly taking any NSAID, having sort of minimal pain and minimal swelling. And interestingly, he had developed subcutaneous nodules during these 11 years, and some of his nodules involuted, and he had Raynaud's on top of everything, and his Raynaud's improved. And then the rash improved. So the take-home point was that in this one patient, this young man finally stabilized with tofacitinib and leflunomide. He became a Jesuit priest, and he stayed active, although no longer able to bike. He was, no longer able to run. He became a biker, a cyclist, and then the pandemic hit, and visits went to virtual, as they did for you. And on the 11th year, just this last year, he first had herpes zoster, and then he had COVID, interrupting his treatment, but also possibly influenced by his drug. With holding the drug for 4 weeks, he flared, and no better way to tell that a drug is working than to hold it. You hold it's called an N-of-1 trial. You put a patient on the drug, see how they do. You take them off the drug long enough to matter, see how they do. Put them back on the drug, see how they do. You have this N-of-1 option, and I use that quite a bit actually in my practice. So he held the drug and flared. What are the risks of the JAK inhibitors? They have substantial risk, and maybe even possibly, depending on the population you're talking about, maybe more than the TNF inhibitors, especially if you're over 50 and you're a smoker or you have cardiovascular disease baseline. There's a signal for malignancy and a signal for cardiovascular events that exceeds the signal for biologics. Again, we're limited by limited head-to-head data and that type of thing. You have to watch the labs, so there's issues of follow-up and compliance. Patients have to come in. If they're on this drug and they're not coming in, this may not be the safest drug. And then the herpes zoster signal, and then there's a signal for arterial or venous thrombotic events. This particular patient, JP's absolute neutrophil count nadired at 1.47 between the start and the present time on drug. But you can see on the far right side of the screen, his most recent neutrophil count has been fine on the same dose. So these case-by-case examples allude to the concept of management reasoning. We've all discussed and heard a lot about diagnostic reasoning, but there's also therapeutic reasoning and management reasoning. This is the integration of information that's very individualized. It's very contextualized. And in that way, it's really different than a clinical trial. It's fundamental to how we make choices. and how we prioritize what to do. In the United States, there's this new fad, you could say, probably not going to go away, a fad that will probably stick, and that's called patient-centered care. So this management reasoning is very heavily patient-centered. They participate in the choices. So we ask the question, what's the choice of management? And the answer is, well, it depends on the context. The context is based on resource availability and cost and your experience, your individual experience, and things like that. In contrast, diagnostic reasoning really is, do you have the diagnosis of rheumatoid arthritis or don't you? It's not really so much open-ended. You sort of make the diagnosis, but management is open-ended. Okay. What about oral drugs? Is there a stigma to being on an oral drug in terms of a positive stigma? And certainly there is. I mean, patients tend to view oral drugs as being safer and intravenous drugs as being more risky. But there's the flip side to the stigma that sometimes you give somebody an intravenous drug, the placebo effect is actually quite a bit higher than an oral drug. So sometimes patients will perceive this oral treatment option as being less likely to help them. You have to take that into consideration. Here are the costs, the monthly costs in US dollars across the board here for the conventional synthetic DMARDs and then the sort of newer options. You can see the price differential between something like methotrexate and the others. And then there's hidden costs. Another patient, this is patient IL. She tells me when I say, hey, Irene, what are we going to do? What's our management decision? She says, well, you're the doctor. That happens here a lot, I think, right? Your patient may have limited health literacy. They may just trust you, more than maybe they should. So Irene is one of my patients that says, you're the doctor, why are you asking me what to do? But it turns out Irene has tobaccoism. She's not compliant with her lab testing. She has hepatitis C, refuses to be treated for hepatitis C. I say, why aren't you being treated? She says, well, I don't care. She's got a philosophy of life. She knows she's not going to live forever. So how do you do informed consent for giving somebody a risky drug? This is the schematic for how tofacitinib works at the cellular level. I mean, how is Irene going to be consented on the use of this product? So patient-centered care has its limits. How do we do informed consent for the mRNA vaccine for COVID? I mean, there's a limit to how much patients can participate. This gets to professionalism and always looking out for their best interests and avoiding some of the booby traps about incentive. But it also asks the question, how do you choose the best racehorse? If you go to the track and you've got 7 horses that could all win a race, how do you pick the best horse? All of these drugs are good drugs. They're all racehorses. So I find that difficult, and patient-centered care can help us with that idea. And then lastly, you don't want to be the last one to use these drugs. You don't want to be the first, maybe, and maybe not the last. So this is Irene's story. She was on sulfasalazine with her somewhat fatalistic attitude about her hepatitis C, couldn't use methotrexate because of the liver. And she was on sulfasalazine for a long time with pretty serious rheumatoid arthritis, and from her perspective, doing reasonably well until there was a supply chain issue. We couldn't get the refills. That popped her over onto Xeljanz. I can't remember exactly why. It was approved by the payer. But anyway, she started it in November of 2021 and did great on that drug. In terms of her liver function and everything else, but she dropped her crit eventually, and we're watching that now. And just last week, she came in with breathlessness and had a cricoarytenoid arthritis flare on Xeljanz, on tofacitinib. So the jury's still out for whether she's going to be able to use that drug long term. A third patient, if I still have time here, I'll keep going. You can interrupt me when I'm out of time. This patient, CS, coping well with classic RA over many, many years, but with the development of damage. This is what we try to avoid with our DMARDs. We're trying to avoid damage. Well, This patient has been on methotrexate since way before 2013 when the electronic health records started. She's still on methotrexate now. But you can see by this chart here, she's bounced off and on biologics, and really never was finding, she was 5 years on a co-stim blocker, abatacept, but never really found herself, stable until she finally hit on the JAK inhibitor in 2019 and has done great on that with her cardiovascular risk factor diet controlled. This is her cholesterol on tofacitinib. It sort of peaked in the third data point after starting the drug and then dropped back down to normal range. So we're out of time. There's lots of other patients I can describe to you, but I think I'll just, for the sake of you're having some opportunity to ask questions, I think I'll just skip over those. I just want to point out this one last patient, initial GG. This poor woman has been on every drug you can imagine with all sorts of complications. And I call it building a pyramid. I mean, it's a very difficult process being a rheumatologist and working with really complex chronic rheumatic disease. On the right side of the screen is a Gandharan stupa from northern Pakistan. You could call it a pyramid if you want. And you know, in rheumatology, we sort of start at the base and then we move up the pyramid. And if we get to the very top of the pyramid, we gotta hope that's helping our patient a lot because now the pyramid's finished. And thankfully, new drugs come along all the time and keep these pyramids growing taller and taller. I feel like tofacitinib is another one of these advances that's helping us provide patients options. Let me just bear with me here as I cut through a couple of my slides. And I'll finish with these. So generally what you're doing in rheumatologic therapeutics management reasoning is you're just finding balance. And if you can do that with your patient's assistance, all the better. On the graphic on the right, you want to be in sort of that high value part of the graph where the benefit's high and the harm risk is low, and you don't want to be on the right side of that, the bottom right side of that graphic. So I'll stop there and hopefully have some opportunity to answer and discuss questions that you may have. Thank you so much.
Thank you, Dr. Dan. Now we'll move on to our Q&A session.